certified radiation oncologist at the New Mexico Cancer Center. Dr. Franklin currently serves as the medical director of radiation oncology at the New Mexico Cancer Center, where he has worked since 2005. He will be presenting on radiopharmaceuticals or theranostics in prostate cancer, recent advanced imaging and treatment utilizing PSMA. Welcome, Dr.
Well, thank you very much. I think first I'd like to thank the Prostate Cancer Support Group for inviting me to speak today. As Jonathan mentioned, I've been at this cancer center for about 20 years, and we have evolved into more than just the cancer center. We have another physicians group called Health Specialists of New Mexico. There are a number of other non-oncology specialties in the building next to ours, like we have 3 urologists and others such. So I'm going to be talking today about radiopharmaceuticals. There are 3 other of my radiation oncology partners. There are 4 of us. We all, of course, do all the standard radiation therapy type of treatments that most people know about. We do a lot of breakthrough therapies and other kinds of treatments, but today, I'm going to talk about something that's a particular interest near and dear to my heart, and that's radiopharmaceuticals. I've always had an interest in that, and it's been that way for about 20 years since I brought it in the clinic after I graduated from Washington University, my residency. So today we are going to talk about imaging and treatment, but due to the time constraints, I decided to go with some of my slides are a little busy. I have bolded areas on the slides that are important, but I decided to leave the busy slides in there for those people that may want to reference it in the future and look for some, if they have any particular interest in specific details on the slide. So I'm probably have to figure out how best to, maybe I'll walk over here to show things. But I think why don't we start, and let me see if I can advance. So, name that. While I'm going to be focusing mainly on, let me just try taking this and walking. Well, mainly, try to look at you guys and my slides at the same time. But while we're mainly going to be talking about imaging and treatment, the first part of my talk is going to be more looking at the history, the what, why, and how of radiopharmaceuticals, of PSMA, just to give everybody sort of a sort of starting point. And we'll talk about PSMA, and then we'll talk about the concept of theranostics, which is a new word that you'll be hearing about more in the near future. We'll specifically then go into imaging, talk about recent PSMA PET-CT trials, and quickly go through some of the data there before moving on to treatment and looking at the pivotal VISION study that got Pluvicto, which is the lutetium PSMA drug, its FDA approval. Talk about some other studies and new trials that are ongoing. So let's first talk about radiopharmaceuticals a bit. These are radioactive medications that can be given interstitially, orally, IV-wise, and these are designed to travel throughout the body and bind to specific cancer cells or areas nearby cancer cells and avoid normal tissues. There are a few main components of this complex. And the first is the radioisotope. I'll get a hang of this in a minute. Which is a radioactive element. This is going to give off various forms of radiation, and in the case of treatment, damaging the DNA of cells, hopefully sparing the good cells. And this radioisotope is linked to a ligand, and this is specifically engineered to target and bind to specific receptors. So a more sort of a general model for this binding, this ligand drug binding is this ligand. So again, this is a ligand that is binding to a receptor on a cell, such as PSMA. That would be the receptor. The ligand would be PSMA 617 in the case of Pluvicto. And this would be linked to a drug. And in the case of what we're talking about today, that drug is a radioactive material, isotope that's giving off radiation either for imaging purposes or for treatment purposes. So this is a specific example of prostate cancer. So this is the prostate cancer cell. This would be the PSMA receptor, a little cartoon. This ligand is engineered by various companies to target this PSMA receptor, and it's linked to an radioisotope, can be used for both imaging and or treatment. So we're going to do, and now is sort of briefly touch on the physics of radiopharmaceuticals, and we'll talk about some of the properties of the decay particles as well. So I think most of you are familiar or have heard of the periodic table. Most of the elements in the periodic table can be made radioactive by either bombarding them with neutrons or protons from cyclotrons or generators. Of course, there are some in nature, naturally occurring in nature, that are radioactive. But radioactive elements are by their nature unstable, and they want to get to a more stable state, and we'll talk a little about that in a minute. On the right here is an example of a helium ion, atomic number 2. It's made up of 2 protons and 2 neutrons, and on the atom there are 2 electrons that bounce off the charge. But in terms of just the ion itself, the 2 neutrons and protons, that's what we call an alpha particle. And alpha particles are one of the particles that we're using, that we'll be talking about, that's important for radiopharmaceuticals. So a stable nuclei is one that is in its lowest energy state. And this is shown on the left. On the left, this is looking at all of the elements on the periodic table, all the stable elements, and they all fall on this line. And on the y-axis, there's the number of protons, x the number of neutrons. You can see they're not equal, and I'm not going to go into a lot of detail about this, but I'll just say that when you deviate from the stable state by adding in or subtracting more neutrons or protons from a given element, that element will become radioactive. And so similar to how gravity takes a ball from a higher energy state, let's say on a slide, it goes down the slide, it falls to the ground, and it stops. Now it's in its lowest energy state. In a similar way, you have electromagnetic and nuclear forces in the nucleus that are trying to get that unstable nucleus to a stable state. Let's see here. So how does the nucleus do that? Well, here's a couple of examples. So here is radioactive iodine, and on this decay scheme, this is unstable, and it's going to a stable xenon state, and it does that by giving off in this case, a beta minus particle, or an electron, and decays to this metastable state, and then it decays down, giving off a gamma ray. So those are the 2 particles that this radioactive iodine emits. In a similar vein, here is radium-223. And by the way, tell me if you can't hear me or not, and feel free to interrupt, by the way, if you really have any questions. Otherwise, we can wait till the end, I guess. But this radium is decaying with an 11-day half-life through various alpha and beta emissions down to a stable lead molecule. And radium-223 is a drug that we use, and it's currently used for treatment of prostate cancer, called Xofigo or Xofigo. Over 120 years ago in 1903, Marie and Pierre Curie first to discover radium, and she was awarded the 1911 Nobel Prize chemistry for that. So radioisotopes, as they decay, they emit particles. And so this is just a cartoon showing the various particles of this unstable state. And they can give off alpha particles, beta particles, which can be electrons or positrons, X-rays and gamma rays. And as you can see in the slide, they kind of show that an alpha particle can be stopped by a piece of paper. Beta particles can traverse in the body a little bit. X-rays and gamma rays, we don't really talk much about neutrons for radiopharmaceuticals, but X-rays and gamma rays require steel and concrete to stop those particles. Okay, so let's see here. So some biologic important characteristics of these decay particles are that alpha particles, that they only travel once they decay from wherever they are landed in the body. They only travel about 40 to 100 microns, very small distance, about 10 cell diameters. They cause double-stranded DNA breaks along the way, and that's how it kills cells. And this is a very powerful, these alpha particles are very powerful cell killers. Beta particles, on the other hand, travel a little bit further, millimeters, so they're still relatively safe in the sense that they don't really travel outside of the body. But they cause single-stranded breaks that can be repaired within the body. There are some advantages and disadvantages with that. And then, of course, gamma rays, these travel centimeters, they travel through our body. They cause single and double-stranded DNA breaks along the way. All right, so now we're going to move from our little physics lesson to a little bit of medicine. In medicine and in science, discoveries frequently arise from careful observation of the natural world and looking at how those effects affect people. And so this is the case for iodine. So in regards to our thyroid. So of course, back thousands of years ago, people didn't know anything about what was on our body, what the different organs were. But what they did know was that people presented with these large thyroid masses in their necks, and it was not that uncommon, and we now know them as thyroid goiters. And ancient Chinese texts noted that these goiters could be cured by eating seaweed over 2,700. That was over 2,700 years ago, and eventually, iodine was synthesized from seaweed in the early 1800s, and that was used to treat goiters and cretinism and some other diseases. And then, of course, a little bit after that, they found the iodine in salt mines, and so that's why we have iodine in our salt. It has also been known for thousands of years that these neck masses sometimes produce other masses throughout the body, and then they kill the person. And so there have been, even in ancient Egypt, studies, or texts, I should say, that have shown how they did thyroid surgeries, even back thousands and thousands of years ago. So people were aware of this. It was something that was obvious. In the 1800s and early 1900s, it was found that iodine is only utilized in the thyroid gland in our bodies, nowhere else. This was kind of the first targeted agent. It was an insight first noted by a physician called Dr. Saul Hertz in New York, or I think actually he was at Mass General. So most scientific, of course, discoveries don't occur in a vacuum. There are prior ideas and discoveries that have built up the foundation of knowledge and a conceptual framework. So even though iodine was discovered in the 1800s, it took Madame Curie, Nobel Prize winning chemists, one of them mentioned here, de Hevesy, Nobel Prize winning physicists, Enrico Fermi, produced first radioactive iodine in 1934, and then of course Dr. Dr. Saul Hertz, who kind of put it all together and said, boy, I think this is how we could potentially use radioactive iodine to treat thyroid cancer. Just putting all those concepts together. So this is a Life magazine article about the very first cancer patient treated with radiopharmaceuticals, radioiodine. This was this gentleman. Of course, prior to this, for thousands of years, thousands and thousands of people died of thyroid cancer. So this man was given by Dr. Saul Hertz's group radioactive iodine. They didn't know the dose. They didn't have any imaging. And he was at death's door. And this article was about 7 or 8 years later. And here he is. And they had biopsied different sites. This was that thyroid cancer originally from a particular site. And that same site shows that the cancer is all gone. So this was the first evidence that radiopharmaceuticals can actually cure cancer. So let's move on and talk about theranostics, which is sort of a bigger idea. And that idea, of course, started with that first patient. But what the concept is it's just combining the two words, therapy and diagnostics. And it is an approach to both diagnosing and treating cancers utilizing, in kind of the modern terminology, similar ligands, which target a precise and specific cancer cell receptor that are linked to the isotope. So one isotope you can use for imaging, the other for cell killing. So this is a sort of a cartoon schematic. Here is, let's say, our prostate cancer cell, PSMA receptor, a molecule, and this molecule attach radioisotopes. Some of them can be used for diagnosis, some for therapy. And this theranostics provides the ability to, in effect, treat what you see and see what you treat. And when you have two pairs, that one looks for the imaging and then one looks for the treatment, those are called theranostic pairs. And this is a brief example. So for instance, if let's say you go and get your PSMA scan, and it doesn't show anything, nothing is lighting up, then of course we wouldn't treat you with a PSMA targeted agent because that target isn't lighting up on the corollary imaging technique. Whereas if the PSMA scan is positive, then we would treat you with, let's say, Pluvicto. And these are just some examples of theranostic pairs. And down here, these are just looking at different therapy imaging isotopes, therapy isotopes, and the target. So in the case of prostate cancer, lutetium is the treatment isotope, gallium or fluoride is the imaging isotope, and this is the binding. And we've talked about there's I-131. We also use strontium for treating bone pain, and this is a bone scan imaging agent, and similar with radium, again, another bone scan imaging agent. So those are just some examples. So now let's switch and talk about what PSMA is. PSMA stands for prostate-specific membrane antigen. It is a transmembrane protein. So it spans both sides of the prostate cancer cell. There's an intracellular component, extracellular component, highly overexpressed in prostate cancer and several hundredfold less expressed in normal tissues. Highest, though, is in the kidneys and lacrimal and salivary glands, and those lead to some of the side effects of the treatment. But important to note, several hundredfold less. So it is like iodine, it is a very targeted kind of a receptor in our body, only on prostate cancer cells. So let's talk briefly about the history. I thought this was interesting, history of PSMA. So first thing, an antigen, that's what it's called. Antigen is a molecule that induces an antibody reaction. Normally it's a foreign substance. And a group out of Buffalo basically put prostate cancer cells into mice, and they looked for antibodies that the mice generated to the prostate cancer. And those antibodies ultimately were determined to be against this PSMA, ultimately PSMA receptor, and that was developed, and that was cloned, and the structure of PSMA was elucidated, Memorial Sloan Kettering in the 90s. The antibody to PSMA was taken by a company, and some of you may remember a scan called the Prostacin scan, and that got FDA approval in 1996. The problem with the antibody to PSMA at that time was that that antibody was to the intracellular component of PSMA, and so you had to have dead or dying cells in order to be able to bind to that PSMA, so it ended up not being a very good diagnostic test for that reason. But teams from the United States and Germany kind of started doing a lot more studying. They ended up coming up with initial diagnostic radiopharmaceuticals, which we now use today, first reported in 2010 to 2012. First clinical testing from humans was 2015. Of course, our first FDA-approved imaging agent was in 2020. So let's try to make this a little shorter, but 80% of men with prostate cancer overexpress PSMA. Expression is independently correlated with tumor stage, metastatic disease, risk of recurrence, and poor prognosis. PSMA, this is PSMA expression on the y-axis. X-axis is increasing aggressiveness of prostate cancer. So in benign prostate tissue, the PSMA expression is very low, and it increases from a primary prostate cancer and goes all the way up to metastatic disease, and that's where the highest expression is. And this study looked at the fact that the PSMA expression was inversely correlated on cells. These are on biopsy cells with 5-year recurrence-free survival. So you didn't express much PSMA, you had a better chance of being alive. If you express a lot of PSMA, your chances of being alive in 5 years are much lower. So now let's switch gears a little bit and go to the imaging aspect of with PSMA, but we're going to talk briefly a little bit about a few other imaging things to sort of set the stage for PSMA. So, of course, we're all familiar with CT, standard imaging studies, CT scan, MRI, bone scans. The problem with these scans, of course, is that they don't directly target the prostate cancer. And usually they see abnormalities, but usually they only see the cancer when the PSA is high, a lot of disease, or the cancer is very aggressive. Many new PET tracers have come onto the market which target the PSMA receptor on the prostate cancer cells, and we're going to be talking about that. You may remember from about 2016 to about 2021, Axumin scans were frequently used to look at prostate cancer. This is looking at a molecule called fluciclovine. It didn't directly target anything in prostate cancer specifically. It looked at amino acid transporters, which is in lots of cancers and in other cells, but it was also elevated in prostate cancer. And so that was initially gotten FDA approval in 2016 for prostate cancer, but other kinds of cancers ultimately as well. All right, so let's talk about what is a PET. We'll talk about PET tracers, PET CT. So, maybe some of you have been in these machines. It's a little cartoon, but basically you're sitting on a table, and there are two donuts here. The first donut is a CT scanner. Second one is a PET scanner. And so on the right here, it kind of shows what's seen, and this is taken from a slice in the pelvis. So the CT scan found these two abnormal areas in the pelvis, and in the case of this person, they were given an FDG PET tracer called FDG, which is a very common tracer in cancer. It's basically looking for sugar. Anything that's taking up sugar binds to a specific receptor, and that's what is looked at here. So on the PET scan part, all you see is this kind of an image, and there's bright spots here. And because these are all rigidly aligned to one another, when you put them together, you see that those abnormal areas are lighting up. So how does a PET CT work? I'm just going to briefly talk about it because it is important for our talk a bit. But basically, we inject a radiopharmaceutical into your body. In the case, let's say PSMA, a PET tracer. And it, of course, goes through all our body and it binds to all the different sites where there might be prostate cancer. there are, as we talked about, various PSMA there are various ligands that are engineered to bind to the PSMA. Here are a few of them: PSMA 11, Polarify, and these are attached or linked to radioisotopes. And typical radioisotopes are fluoride, radioactive fluoride, gallium. There's copper. There's carbon. But they all have one thing in common, and that is when they decay from their unstable state to their stable state, they give off a beta positive particle, or what's called a positron. And so what happens? Well, here's an example of a brain, slice in the brain where there's an abnormality. And this is the ring of PET detectors called coincidence detectors. And what happens is that the drug binds to that cancer cell here, and when it binds there, it gives off this decay particle with a half-life of about 110 minutes. And what happens with positrons is they immediately find an electron. They both annihilate each other. They have a unique property. When they annihilate each other, they create two photons, each with this gamma ray energy, exactly 180 degrees apart from one another. And these detectors look for both of those gamma rays almost at the exact same moment in detectors that are exactly 180 degrees apart from one another. And so by looking at the slight time difference, you can figure out where in that slice that positron and electron annihilated each other. So that's how you get that image that I showed. And I'm not going to get into too much detail here, but when we talk about tests, and we all take for granted that, oh, this test is showing something here and this test is not showing anything, like this PSMA test or the CT scan. The question is, well, is it real? And so I won't get into a lot of details, but when we talk about imaging studies, the key terms are sensitivity, specificity, and positive and negative predictive value. The sensitivity of a test is its ability to correctly identify those with a disease, meaning that a test with high sensitivity identifies those who truly have a disease. Specificity is looking at those who do not have the disease. So a high specificity of a test identifies those who do not have a disease. And then their positive predictive value, this is sort of more important from a patient perspective, and that is when you come into your doctor's office and he says, oh, here's your PSMA test, and it's showing, it's lighting up. If the PSMA test, let's say, has a high positive predictive value, then you can be pretty confident that, in fact, that test is showing the disease. And if the test is coming back negative and the test has a high negative predictive value, you can be reassured that you don't have it. So just one of those things that I'm not going to get into much, but I will briefly talk about fluciclovine. And here is just a study that looked at sensitivity and specificities and positive and negative predictive values compared to the CT scan. Not the best image, but basically the fluciclovine, bottom line is, does a much better job than the CT scan, shown in yellow for various PSA values for detecting cancer. And it starts to lose its efficacy when you get to PSAs less than 1 for Axumin scan. There are two interesting trials. I'm not going to talk much about it, but these were trials that looked at whether you could use CT or Axumin to direct the radiation fields for a recurrence of prostate cancer following a prostatectomy. And the bottom line from this trial that's done at Emory University, that they found that the Axumin scan changed the treatment in a third of the time. And not only that, but probably most importantly, it improved the survival of men who were treated with Axiom versus CT. And that's really just because you're not treating men, let's say, if there's disease outside of the prostate or pelvis, whereas you might have in the past. So this is one of the only tests that it actually, this is one of the only studies of looking at imaging tests that have shown a survival advantage. The new trial is comparing gallium PSMA scans to Axiom, but for the same thing. So before we get to, again, this is another one of my busy slides, but before I just going to highlight a few things. Before we talk about PSMA, do want to say that currently there are 3 approved PSMA tracers on the market today, FDA approved. And they all have the same 2 kinds of studies that got their FDA approval. One study in initial diagnosis and another study in recurrence. So if you have a, let's say, an intermediate risk or a high risk prostate cancer, these PSMA tests are all paid for initial diagnosis. You don't just have to have a CT scan and a bone scan anymore. And as you'll see on some of these studies, they do a much better job than CT and bone scans. But also, if you've had treatment and you're looking for recurrence or progress, let's say if your disease is progressing, that's also covered. And those are the indications down here that the FDA has set for all 3 of these imaging agents. FDA approved of gallium-68, this is the isotope, PSMA-11 is the ligand. It was FDA approved in 2020. The commercial kits are called Illuccix or Locomets. There's a Pylarify, which is a common one. This DCFPYL is a compound, a proprietary compound that binds to PSMA. F18 is the isotope. And then the most recent one is called Posluma. And this is a radiohybrid. I won't get into it, but it's, again, these all have different binding ligands, and they use either the F18 or the gallium-68. So just briefly going through, really, again, some of the highlights here. These are the 2 FDA-approved studies. This is an initial diagnosis study. They found for the PSMA scan that the overall sensitivity was 47%. Patient-specific positive predictive value was 67%. Higher Gleason scores in PSA and other analysis showed that it did a better job. And in this study, this was looking at pelvic lymph nodes taken from a radical prostatectomy sample and comparing to what the imaging showed before they did the surgery to see, okay, was that lymph node actually cancer? And then this is the recurrence trial, and they didn't really have, none of these studies have sensitivity and specificity in these trials. They just use terms like positivity rate. So we really don't know a lot, but it does show a higher positivity rate compared to CT scans or other imaging studies. So here's another study, and I'll just highlight this. Here is a metastasis on this right iliac bone for this patient, and you can't see anything on the CT scan. So that's what PSMA does for you, and that was biopsy proven. So this is a much more sensitive test than PSMA, and you can see it here. The accuracy was 27% greater than CT scans. This gentleman right here, these little areas in red are all metastatic lymph nodes. That's what the gallium PSMA test showed. And here is an example in the pelvis on the CT. You can't see anything there in the presacral region, but here it's lighting up in this tiny little lymph node. And there's another tiny little lymph node here that would never have been called by the radiologist. So, and then this person was given androgen deprivation therapy, and it all went away 6 months later. Here's another study, another important study, but basically this looked at a lot of patients, and they found a sensitivity rate of 42%, specificity rate of 95% for gallium PSMA, and then these positive and negative predictive values. And I'll kind of sum up everything in a minute, but these are the 2 studies for Pylarify. Sensitivity on the initial diagnosis study was about 40%. Specificity was about 98%. In the recurrence trial, they found that 85% were felt to have a correct quote-unquote localization rate, not a real term we use, but all of these companies, of course, want to get their drugs out and get them used. So sometimes they kind of make up terminology. And this is the Posluma two trials. In the initial diagnosis trial, they found a sensitivity of 30%, specificity of 95%. In the recurrence, they found a sensitivity of 64%. So what does that mean? And this is, in my opinion, in summary of all these studies, that PSMA scans are the best we have, but they're not a home run. Because of the sensitivities in the 30 to 50% rate, those are, again, true positives. All of these tests seem to do better in detecting when a patient doesn't have prostate cancer or doesn't have disease, because that's what a specificity is. So if you have a negative scan, you're a lot more confident in that you don't have cancer, as opposed to a positive PSMA scan where it may show lots of various sites, but maybe some of those sites aren't real. And that's really what the sensitivity in 30 to 50% comes down to. I'm also awaiting this ongoing EMPIRE 2. They're comparing Axumin to gallium and F-18 PSMA. And there are a number of other imaging agents being tested with different ligands and some different isotopes. I ran a study, phase 2 study, looking at copper in a recently published at ASCO in an abstract, and it's called the COBRA trial, and we put a number of men on that trial. And the copper imaging to this separate ligand called BIS-PSMA looked pretty promising, and we're starting a phase 3 trial in our clinic on that early next year. So now let's switch to treatment. And what we'll pretty much do is kind of talk about radiopharmaceuticals that we use. We'll briefly go over that and some interesting studies from radium. We'll discuss, then move on to PSMA, mainly Pluvicto, talk about the imaging studies there, and then recent results in the pre-chemo space for these studies and other trials that are coming down the pipeline as well. So this, I think you've all seen it. This is this kind of a graph like this. This is sort of PSA on this axis, and this is going from least aggressive to most aggressive prostate cancers. And, you know, as you treat the patient, as the patient gets treated with either radiation or surgery, you know, the PSA drops as we control most of the cancer. Hopefully we cure you of those treatment modalities, but if we don't, PSA starts rising at some point. We give the androgen deprivation therapy. PSA drops again, and eventually the prostate cancer finds its way around androgen suppression and becomes metastatic. And of course, that's metastatic, and we call metastatic castrate resistance when that testosterone level, as you heard in the talk before, is less than 50 nanograms per deciliter. So prostate cancer spreads to the bones when it becomes more advanced. 90% of men with advanced disease develop bone metastasis. And what happens is those prostate cancers go to the bone, and we won't go into all the details about it, but they create sclerosis. They induce bone turnover and bone growth around where the prostate cancer cell lies. And here's on this periodic table, these are the alkali earth metals. And you see in this line here, we've got calcium, strontium, barium, and radium. And what happens is calcium, of course, is what's in the bone and what gets deposited in the bone as that bone's being induced to grow by the nearby prostate cancer cells. But if we give patients strontium, which we occasionally do for palliation, or radium-223, Xofigo, they basically go into these spaces where the calcium would go in the bone, and then they give off their radiation and kill the nearby cancer cells. At least that's the theory. We give strontium occasionally. It is good for analgesia. It lasts for about 6 months in terms of pain for most men and well tolerated. It's used for other sites other than prostate cancer. But of course there's no survival benefit with strontium. So the two drugs that are NCCN category 1 for treatment are these two drugs provide a survival benefit in men with metastatic castrate-resistant prostate cancer. We're not going to talk much at all about Xofigo, but we've offered it since 2013, hundreds of patients treated. It does improve survival by a similar amount to the Pluvicto, close to 4 months. It does a better job pre-chemo, and it improves quality of life. And the Pluvicto, the PSMA target drug, does the same thing. It improves survival, and it improves quality of life. And we'll talk a bit about that. We've offered it to our patients in mid-2022 and treated a number of patients, most in the state since then. And so I'm just going to briefly digress to talk about some interesting radium data. So the radium, again, gets deposited in bones. The initial Alsimca trial, which published in 2013, shows survival and quality of life benefit. As I mentioned, it's more effective and less toxic if it's given pre-chemo. But the interesting trial results that came out are from the Peace 3 trial, and that just came out in the European conference in September of 2024 in abstract. And what that showed, what that trial looked at, was men with progressive metastatic prostate cancer who had been treated with androgen deprivation therapy like Lupron or Eligard. Spelled that wrong. But no chemo or other novel androgen receptor agents like Zytiga or enzalutamide or any of those newer, more modern drugs. And what they did was they had two arms in the trial, Xtandi and Xtandi plus radium. And they found a 31% improvement in progression-free survival and overall survival with the addition of radium with the Xtandi. And so this may be a new standard. We're going to wait for the final publication. But this would be a new standard of care for these men in this scenario with metastatic castrate-resistant prostate cancer. And we'll talk about some of the data with the PSMA drugs in the pre-chemo setting as well. But this is looking at radium in the pre-chemo setting. We have an ongoing trial at our center looking at chemo docetaxel with docetaxel plus or minus radium. So everybody gets docetaxel, but in addition, you could be randomized to getting radium as well. Radium is looked at in immuno-oncology with PARP inhibitors, with a number of other drugs, and a number of other ongoing studies. Okay, so now let's switch to Pluvicto and PSMA. So this is a prostate cancer cell, and there on that, there's a PSMA receptor, this sort of a magnified area. And here is sort of a cartoon of Pluvicto. It is the ligand, the engineered ligand, PSMA 617, and it's linked to this lutetium-177, which is a beta emitter, gives off those electrons, and that what damages the DNA. This complex, once it binds, gets swallowed into the cell, and then the irradiation not only damages the DNA of this cell, but nearby cells, cancer cells as well. Again, the beta emitters travel millimeters in the body, so they're damaging cells within a couple of millimeters around where it lands. The Pivotal Vision study, it was published in New England Journal in 2021. It's, again, looking at lutetium-177 linked to this PSMA 617. I'm proud to have been one of the 42 investigators in the country I put 11 patients, randomized 11 patients, state of New Mexico, back in 2018 and 2019 with this drug. Out of the 831 patients who were randomized, one of my patients, and this gets more of the headlines, but this certainly is not the common outcome for this drug. But one of my patients had a phenomenal response. His PSA dropped from about 2,000 to 3. He lived another 3 years after the trial concluded and without treatment for 1.5 of those 3 years. The FDA approval was in March of 2022, and I gave the drug the day later. So this study looked at men with progressive metastatic castrate-resistant prostate cancer that had positive PSMA scans, that had previous chemotherapy and a novel anti-androgens like Xtandi or Zytiga. And those men were randomized to best standard of care, to best standard of care plus Pluvicto. I'll call it Pluvicto. It wasn't called that at that point. But the Pluvicto was given up to 6 cycles. It's given every 6 weeks. And during the trial, there was blood check regularly at 3 and 5 weeks, which is what I do. But also during the trial, which I don't do, is they get CT and bone scans. They got CT and bone scans every month and a half throughout the trial and after the trial. The primary endpoints were radiographic progression-free survival and overall survival. And here's the data from the trial. This is the Pluvicto arm. Statistically significant improvement in median overall survival, 4-month improvement. All of the subgroups of patients, they're to the left of one here, but of course some of these error bars are large because there are small numbers of patients. But you can see, like here, for instance, as an ECOG 2, there weren't that many of those patients. So this is not a drug that you give to very debilitated people, the drug that you are going to give to people who are doing pretty well. This is a radiographic progression-free survival. What does that mean? That means the images look better. CT and bone scans look better. And how long do they look better for? On the Pluvicto arm, this gets extended by another five months. So they stay good for an additional 5 months over what was the best standard of care at that time. This is a waterfall plot looking at PSA response. And about half of the men had PSA responses greater than 50%, and about a third of men had PSA responses greater than 80% on the Pluvicto arm. So on the treatment side effects, half of men have very little or no side effect. Those that do, half get fatigue, half get some sort of bone marrow suppression, which is the reason why we have to look at the bone marrow. Most of that is due to anemia, so your red cells drop, but in a small percentage, of cases you can have platelets dropping and white cells dropping. 40% get dry mouth. That's due to, again, that lacrimal and salivary glands that do express a little bit of PSMA, and you get a little nausea, vomiting. There's a little bit of PSMA in the gut, but when you look at the more significant side effects, grade 3 to 5, you see the most significant is probably anemia. So your red count drop requiring some kind of support in 13% of the time, either shots or infusions. But the rest of the other ones are pretty low. So this is a very well tolerated drug. That's the bottom line. Bone events are delayed by another 6 months. Things like fractures, pain, and quality of life scores on the trial were much higher with the Pluvicto arm. So people did better, and they had less pain. Here's an example of one. Pre-Pluvicto, you have disease in bones and lymph nodes, and then after 6 cycles, the only thing you see here is where the normal uptake of that PSMA is in some of the gut, salivary glands, kidneys, and it gets excreted in the bladder. And of course, that was one of the men who had a very good response to the drug. And just some details of it. It only takes 5 minutes to infuse the drug. Men go home after. It does get excreted in the urine. This is really only concerned for men that have incontinence, let's say following prostatectomy, and there are some things that I do to prevent or to provide a safe environment when they go home for their family members. Because it is a beta emitter, there is minimal radiation precautions, and generally these men have to be alone for 2 to 3 days. But then they're free to go about their lives for the next 6 weeks till their next infusion. Maximum 6 administrations every 6 weeks. Check blood work every 3 and 5 weeks. This is an important trial comparing a well-tolerated chemotherapy called cabazitaxel to Pluvicto. Bottom line, no difference in survival whether they got chemo or the Pluvicto, but PSA responses, adverse events, quality of life, all of that was much better in the Pluvicto arm than in the chemotherapy arm. And this is the PSMA trial landscape. So I'm not going to, there are all over the world over 100 trials now where people are looking at either in the preclinical or in the phase 1 setting, looking at PSMA combined with other things as well. And here they're looking at, again, in that graph of PSA and more aggressive disease. These are studies looking at it in clinically localized prostate cancer. Here are some studies looking at it in biochemical response, hormone-sensitive metastatic disease, metastatic castrate-resistant pre-chemo, and this is the VISION study, which is in the post-chemo phase. So I'm just going to quickly talk about 2 studies, the SPLASH and the PSMA-4 study, looking at Pluvicto or Pluvicto-like compounds in the pre-chemo space. So to get Pluvicto currently, you have to have chemotherapy. So the PSMA-4 study basically looked at Pluvicto plus or compared to a change in your androgen treatment. And what they found was, let's see, maybe if I go down. Anyway, what they found is that there was an improvement in radiographic progression-free survival, meaning the images look good, but no difference in overall survival. And this was based on the third interim analysis published in abstract, just came out a couple of months ago. So there's one more interim analysis before they'll publish the results. So similarly with the SPLASH trial, this is looking at the same isotope lutetium, but a different PSMA binding ligand than what Pluvicto uses. And a similar trial design. I was running this trial. I placed a number of men on this trial in Mexico. And this trial was given 4 treatments every 8 weeks instead of 6 treatments every 6 weeks. But in the first interim analysis published the end of 2023, there was no overall survival benefit so far, but all of the other parameters, very similar to the PSMA-4 trial, all other parameters were better with the Pluvicto. And so why is there no survival benefit in the pre-chemo space as opposed to the post-chemo space for the exact same drugs? And so what people think is because they allowed on the trial, well, there was actually 2 things. One, the drug companies didn't put overall survival as a primary endpoint. They put it as a secondary endpoint because they wanted to get their drugs out. But they also allowed crossover. So in the PSMA-4 trial, about 60% of patients crossed over when their images started to look worse. And that's why, so it improved the radiographic progression-free survival. Images look better. But as soon as those images started to look worse on the trial, those men were then allowed to get Pluvicto. So there wasn't enough time to show a survival benefit because that was like 6 or 7 months on average later. So they think that there was no overall survival because of the confounding factor of this high crossover. And that is the reason that with that no survival benefit, the FDA has not yet approved these drugs in the pre-chemo setting. It is possible that by the end of the year, though, they might, due to all of these other good results. Current PSMA trials in my center, we're just about done here. One is called the PRESERVE trial. So this is for men who basically, let's say, would be sent to me for Pluvicto. But this trial is looking at Pluvicto plus or minus this other compound called ONC392. That is an anti-CTLA-4 antibody that basically increases T-cell activity. It's like an immunotherapy. It increases T-cell activity in the tumor. And so those men, everybody gets the Pluvicto, but you could get this other medicine with the Pluvicto as well. That's the PRESERVE trial. We have that going. And this trial, the FUSION trial, is what we're starting this upcoming month, in our center. This is looking at a phase 2/3 study looking at actinium-225 PSMA INT. So this is a different ligand than Pluvicto, and it's using actinium, which is an alpha emitter. So there are some important differences. It's alpha emitters, if you remember earlier, they have a much shorter interaction. There is no radiation safety precautions because they're only acting over a short distance, but they're hitting things much harder. And so that trial is for men who have been treated with Pluvicto. So if they've done reasonably well with Pluvicto, they're a candidate for getting on this trial. This is an example of actinium. Here, 4 cycles. In this case, PSA went from about 3,000 down to undetectable. One interesting side effect that we'll find out on the trials, but it seems like in this large retrospective study of lots of other studies, that dry mouth is much stronger in this actinium than it is in the lutetium. And there are a number of other ongoing trials, and we'll get to it, but UCLA, they're running, one of those places is running this trial, giving another 6 cycles of Pluvicto. There are trials combining Pluvicto with immunotherapy, combining with antibody drug conjugates. There are different ligands that are being looked at, different radioactive drugs. Here's an iodine tagged to PSMA. There's CAR T cells. I mean, basically, this area is going to be mined for the next decade. And we have a lot to learn about PSMA, just PSMA receptors itself, and I'm pretty excited about this field, so thank you. Go for it.
I have a couple of questions.
Sure.
Number one is, should a PSMA PET scan be done? Well, who are the candidates for a PSMA PET scan? And number two, my understanding is that PSMA scanners were or are only available, there's two in California. Is there one in Albuquerque?
So let me start with your second question first. So what you're remembering about the California at UCLA was when the initial FDA approved gallium-68 PSMA, that's a PET tracer, but they only approved it in a non-commercial form. And there were only a few places at UCSF, UCLA, a few other places that were actually, they had to tag their own gallium to this PSMA. So there were only a few places in the country that were doing it in 2020. So that's the reason. This is used on this PET scanner that every place has. The only difference is this is just the infusional drug that we give you. So it's used for the same PET scanner that are used in standard oncology. It's just instead of, let's say, giving FDG, you're giving this PSMA PET tracer. And it's available, I think, at every place in the state. Is doing PSMA scanners. It's not the scanner is the exact same as we've been using for a decade. It's just what we infuse in you. And as to who should get the drug, so if you have low-risk disease, sort of NCCN defined low-risk disease, insurance companies probably won't pay for it. Medicare, of course, doesn't know. But generally speaking, those are low-risk disease, Gleason 6, PSA less than 10. Those are men who wouldn't get any scans anyway. So it's not really indicated in those kind of men. In men that have, say, favorable intermediate risk, maybe a Gleason 3+4 equals 7, maybe a PSA less than 10 or 20. In those men also, it's not really indicated because the chances of metastasis are low. But once you get to unfavorable intermediate risk, maybe a Gleason 4+3, or maybe Gleason 8 to 10, or higher PSAs, those men in higher intermediate risk and high risk or metastatic phase, those are all indicated and and those men should all get a PSMA scan. And the suspected recurrence is, let's say you've had a prostatectomy and now your PSA is starting to go up. Well, the FDA has approved this drug for these three imaging agents currently for looking at to try to find where is that cancer from that elevating PSA. So, the days of CT and bone scan are really pretty much gone. I think a lot of people use it, but I can tell you, I will frequently, even if they got a CT and a bone scan, I will frequently get on top of that, get a PSMA scan because it just shows so much more, and you can be surprised. As they did in that Empire trial, there were essentially a third of men that found new areas compared to that CT and bone scan that weren't there before. Happy to take questions after during our break if there is one.
Thank you, Dr. Franklin. We're going to take a 10-minute break, and then we'll be back. Thank you.